And I'm wondering if anybody can like throw out their idea of like, what do you kind of recall about an ACO and what you thought it was? Maybe Trinity, might you give a stab at that?
I can try. Um, so my understanding of the ACOs is it's like a group of different like hospitals, I guess, or doctors and whatever providers, and then they're working together. Um, I remember it was like something to do with I think Medicare, or the now I'm like forgetting what it was because I think it was a while ago that Dr. Malek talked about it. But I think there was something to do with these different groups collaborating to like provide supposedly more cost effective or like cost controlled care. I don't know
We can adjourn right now
if
since that's correct.
okay.
Thank you for your bravery there.
That's the whole idea.
Does anybody want to
Later
add
on,
anything that they remember?
I'll just repeat what Srinidhi just said. But anyway, yeah. Good memory. I'm impressed. That was one of the least memorable things in this entire internship. So nice going. Betty,
And
did
Anna,
you
do you
have other
remember?
questions to ask anyone? Or since Trinity's now aced the whole thing?
Yeah, yeah. And Anna, do you have any recollections of anything to build on what she just said?
If I'm being completely honest, I do not remember that acronym at all, and very thankful for Trinity's review.
Oh dear. Okay, so it sounds like it's distant enough that yeah, Dr. Malik should just go ahead with kind of refreshing people's memories before more discussion. Thank you, and great
Yeah,
job, Trinity.
yeah, that was impressive. And the other part of it, so you got to hear the term management services organization from Dr. Hayden Brookley, trouble with his name, Brookley. Anyway, the fellow who talked last Friday. And we actually he didn't define it, and I haven't used the term. So today we'll define it. And let me see if I can find it. Yeah, I think I got the right one. Okay. Okay, so can you see something that looks like a slide? Yeah, okay. Okay, so management services organization. This is the definition. I looked it up. A business entity that provides a range of administrative, operational, and financial management services to healthcare practices. They can include billing and revenue cycle management, human resources, personnel management, just doing payroll, regulatory compliance, IT infrastructure, which means the software, hardware and software you're using, vendor negotiation, and marketing support. Now, if you did all of that, that would be pretty much, other than lobbying, that would be just about everything manage a management team or a CEO is responsible for. That's a lot. So if you had a management services organization, which I'll start calling MSO, that did all of these things, they would be in a pretty strong position to buy your practice and run it if they had the capital to buy your practice. And since everything, at least in the healthcare part of our country, seems to uh, merge and get into big money, a lot of them have the money to actually buy practices. And certainly the corporate ones, private equity capital by definition has a lot of capital. So they could do it and run these things if they wanted to. So, but the concept is the providers contract with these, especially the all service types of management consultants. You can call them consultants. So a provider could contract with them. Let's say you just didn't want to do payroll or you didn't want to do billing. You could hire a management services organization and they would do it and you'd pay them in some manner, either by the case or by number of bills or the percentage of billing that they collect, or find some way to pay them. And then you get to spend more time on being a doctor rather than having to deal with this administrative stuff. So that's the logic. Now, what the Dr. Rookley talked about the other day was an MSO, which actually is simply taking over the entire practice and owning it and running it. But it's occurring in a state where that's not legal because of a corporate practice of medicine prohibition. So in that case, the corporation buys a majority stake in the practice. So they spend all the money. The doctor who sold out has received the money, but they install their own guy, their own doctor, who's going to get paid a whole lot of money to take on the title of medical director. Whether or not that person actually even lives in the same state, they may have to get a medical license in that state. So that might be a criterion. They have to get the doctor credentialed in this relevant state. That's a cost. And so they install their own doctor. They get rid of all the current management team unless they have some reason to keep them. But they got their own management team, and they form they basically serve as managers. They use their management team to perform all the different services that I just mentioned, personnel, payroll, all that stuff. And all of the medical director and MSO actions are then approved by the corporate de facto owner. So whoever owns it has installed this doctor as medical director and is using their management team or potentially even a contracted team to serve for all these non-clinical administrative functions. So that's sort of a MSO takeover, which is what the fellow the other day was talking about, because they want to prevent these de facto corporate takeovers. So a fake MSO that's actually running the whole thing and bought it. So you could imagine there's almost like a little bit of a fine line where some doctor was so uninterested in the management that they hired one of these all-encompassing, all-purpose management services organization to run the whole practice. And they're, to the point where they may be pretty uninvolved in management. That would be sort of another possibility. But this one on this slide is where there's actually a de facto corporate takeover. At a much narrower extreme, practice could simply subcontract out a specific function like billing. And that could be done by a generalized management service, or it could be done by a specific company that only does billing for doctors. And those do exist. Or only does accounting. For those of you who listen to National Public Radio, there's been this firm called Your Nonprofit Accountant or Controller. Your Nonprofit Controller. You might have heard that advertised. And those are people who contract out accountants for nonprofit organizations, and they pay, they charge for doing that accounting, also known as control. Anyway, and another form of contracting is for staffing, which I talked about earlier, that it's actually for medical and nursing staffing to be privatized. turns out to be really, really inefficient. Because the doctors who are looking for jobs don't get to find out all the jobs available in the area, and they're have very high overhead, so the overhead cost and profit actually are both pretty high for these organizations. So that could be contracted out, and often is, especially by rural hospitals who are kind of desperate and can't afford to put an ad in the New England Journal. So that can be contracted out. And then personnel management could be contracted out. So you could contract out specific functions, or you could contract out all or most to a medical services organization. So, and I'm back to talking about where some corporate entity is actually not taken over, but you're still the de facto owner, but you just don't want to do the administrative stuff. So I'm going to stop right now and ask for questions. So this is like perfectly clear. Nobody's saying yes, so it's not.
I think it's pretty clear so far.
Okay. All right. So the other thing that got confused with this the other day was ACO. The term ACO got used, and the reason it got used is because these sophisticated management service organizations that are doing all these functions in the second paragraph, billing, revenue cycle management, human resources, all of this stuff, they can handle complex data and negotiations. So now that we have the Medicare program, their little CMMI unit, Center for Medicare Medicaid Innovation, that's part of the Medicare program. Now that CMMI is obsessed with value-based care and those related schemes as the only cost control measure they're willing to talk about, or they have talked about in their 12 years of existence, nothing else, only value-based care. This created a market opportunity for reasons that I'm about to get to. Now, I was going to give the example of ACO REACH, was just one, but keep in mind that this CMMI, this little division of Medicare that spins out new programs, it's the Innovation Center. So every innovation within Medicare is supposed to go through this little division of Medicare. And they have $1 billion a year budget. It might be a little more by now. And they keep spinning out new programs. And these programs fall into 3 categories. One is sort of a miscellaneous category that includes an end-stage renal failure and some other very specific programs. But the 2 main categories that are more of these little schemes out of the CMMI, the 2 main categories are problem-related schemes, diagnosis-related schemes, and bigger picture schemes. So on the problem-related schemes, there's not as many of these, but they had one for knee replacement. So instead of a hospital billing the usual way for a knee replacement to an insurance company, what would happen here is that there would be a prospective payment, an amount of money. A company might say, we want a knee replacement rate. This is the amount of money you get to do a knee replacement. And that's from the preoperative visit to the operation, to the postoperative care, to the rehab center, even if that's in a different facility. And there would be one payment for the whole shtick. And as is everything else within these prepaid schemes, a patient with end-stage heart failure who's really out of shape is going to be a much higher risk candidate for a knee replacement than some person who's incredibly healthy who just busted their knee, from a fall or something like that. The risk will be very, very different. And so they had so they stick in risk adjustment schemes so that the sicker patients who have a worse prognosis, they might get paid more to treat those people. So now you're adding more complexity. And so there's a bunch of programs like that. But they were kind of small, and it really wasn't, and it was hard to integrate that into a whole insurance plan. So, like if somebody goes into heart failure, it starts to become a heart failure operation, hospitalization, and you could say it's no longer a knee replacement, as opposed to a knee replacement hospitalization in which a patient with heart failure might need an extra dose of a diuretic along the way, but they're basically not in florid heart failure. So you get into all these issues of like, when is it still the part of that episode of care of knee replacement versus the patient's general health? Like, what if they get really depressed post-op because they have more pain than they thought expected, and they get really depressed? Is that part of the cost? So it's hard to tease all these things out because your patient is one human being and they're not just a knee. So it's problematic for that reason. So now let's go to Mackenzie's question.
I was wondering kind of what the difference. So I know like HMO is like capitated per person, and then this is like per operation or per situation. But is it kind of similar to like an HMO style where they have to like budget the money like by deciding like how much care they're going to give the patient with that set amount of funds? Does it run into similar problems that you might see with some HMOs, or is that not so much related?
Yes, yes, and thank you, because that's going to introduce us to the next section of this talk, which is, so what I was getting at with these problem-oriented prepaid schemes, like knee replacement being the classic, they were limited, and they're trying to take a piece out of a patient's life. So what Mackenzie's getting is, you could write this large and say, well, you could just prepay for everything that might happen to a patient in a year, and not just their knee, if they needed a knee replacement. So you could prepay all the care for an entire year, and that would then be an HMO. What an HMO was trying to be originally, and even what it evolved to be. It's essentially a prepaid scheme for a year of care. And when you also think about it, that's really what an insurance company would be doing. So back to Mackenzie's question. So the original HMOs went beyond just being an insurance company paying for a patient's entire year of care, but they were the doctors and hospitals providing that care. So in that situation, you have something like Kaiser, which owns salaries all the doctors and owns all the hospitals they use, and functions as the insurance company too. So that was really the original conception, that you would take the insurance function for an entire year of patients' lives and then provide all the care yourself. However, that evolved, and eventually regular old insurance companies got tired of doctors just ordering tests that then cost them the insurance companies a lot of money. So from that, schemes developed to go part of the way in making the doctor and hospital together in one group, to make them into an insurance company stated otherwise, to absorb risk for patients who got expensive. Essentially blaming the doctor for patients who got sicker. Like if you hospital and doctor team, if you provided really good preventive care, these patients wouldn't need all these procedures. You're a failure. Or you're greedy and you're ordering too many tests. And so we're going to make you sensitive. We're going to make you at risk. We're going to make you feel like us, like we're insurance companies. We're victimized by all this stuff you order, all these stupid tests and treatments. Now we're going to make you feel some of the pain. You're going to lose money if your patient needs a lot of care. So there's partially, in the case of Kaiser, they totally converted, added on the insurance function. But all the rest of this stuff that we're talking about, what it does is go part of the way in making the doctor into an insurance company, the doctor and hospital team. Mackenzie, I want to go back to you. What do you think? Does this kind of get into what you were thinking about, or what do you think?
Yeah, I think I was just kind of curious, like how those, because I feel like in concept, like you said, like the risk sharing between the HMOs and the ACOs seemed very kind of, same thing, different version, like two versions of the same thing.
Right.
But I feel like that addressed that, how I was wondering how they were similar.
Okay, now I just created this slideshow like in the last 8 to 10 hours or so. So I don't have a slide on this yet, but I do want to say that one difference between this classic HMO, where you're just 100% both provider and insurance company, you're doing the whole deal. That one difference between that and an ACO is that the ACO, as conceptualized 20 years ago when it was being developed, didn't get rid of the insurance company. They didn't integrate the insurance company into the scheme. They left them in. So, in other words, we already had a system with very high administrative costs, and the insurance company is still paying all the bills. But now there's a whole nother entity added on, one of these schemes out of CMMI and Medicare, to try to partially make doctors into insurance companies so they would feel the pain and they would control costs better on their own. And the reason this happened is it's a legacy situation where people like me who are stubborn and don't want to be in Medicare Advantage for all the reasons we've discussed and have these insurance companies intruding, we wanted to have regular old coverage that wasn't going to second guess my doctors. So we insisted on buying traditional Medicare, with Medicare paying the bill, part of the bill, and my Medicare supplemental plan paying the rest of the bill. But from the point of view of Liz Fowler, her quote, that she didn't regard that as accountable care. Doctors are out of control. They're unaccountable if you leave them unleashed and unrestrained. So we're going to throw onto traditional Medicare another entity, and the goal of that entity is make doctors lose money if they order too many tests or the patient gets really sick. And that was how the privatization, the ACOization of traditional Medicare started up. Doctors were ordering too many tests, and so we're gonna somehow foment a disincentive scheme so that doctors, rather than ordering so many tests because they don't feel the cost, or even profiting themselves if they're ordering a treatment that they themselves are going to then do. So we're going to make you lose money if you do too much and order too much, or the patient gets sick. So that's the genesis of all of this ACO stuff. And this is the largest portion of what CMMI works on. Some of them, there is the term ACO, and that used to mean a specific one of these. And then they spun out more. Now there's 20 or 30 different programs. They got different names. Primary Care First is one of them. ACO Reach is another one. There's another one with community. They have all these nice sounding names like community care, whatever. And anyway, so there's a lot of names. So basically, they're all little slightly different schemes for shifting away the incentive so that doctors lose money if the patient gets too much care. Now, the original ones, the first ones, were not schemes where the doctors lose money if their patients cost a lot, but where they gained money if their patients cost less than average. So that was called a one-way risk thing, where the doctor might make extra money if the patients did really well, but wouldn't lose money if they did badly that year. And this is their whole patient population in aggregate. You're not talking about, they weren't talking about each individual patient, but the aggregate of all the patients in that practice or for that specific doctor. So that was a kind of one directional incentive system where it was win only. And those have been popular, and because it was sort of a win, I'll get a caveat on that in just a second, but right now, and so those have been popular, but what they really want at CMMI is for the doctors to lose money if they have very sick patients, and not just to gain money if it's the opposite, if their patients do well. And the Trump team now has reiterated that they don't like these one-way schemes where it's only win. They want the practices to lose if their patients are ill. Anyway, so that's kind of been the motivation. And so now you guys, probably a lot of you, I mean, you're all really smart. You got into medical school and you're there. So some of you might be like really good at math. And if you wanted to come up with what I'm going to ask is how do you do that? Like, it's very simple for the old system where a doctor did a test and then billed for it. That's straightforward. And then money comes in for that procedure. So that's direct, that's obvious. That's called the fee-for-service system. But again, the economists all hate that because the doctors don't feel restrained from ordering too many tests because they get paid more, or at worst are neutral if they refer to someone else to get that money. So they want to create a disincentive scheme. But how do you do that? Because if you're trying to, let's say the doctor's thinking about ordering an MRI of your brain, but the doctor's thinking, well, the alternative, I could wait and have them come back in a week and see how it went. And maybe their headache's gone or their twitching movement just went away. And everybody's just going to say, oh, it got better. We don't need that test. So, and let's say that's exactly what happened. The doctor says, I'm concerned about this. I don't have a specific treatment right now, but I want you to come back in a week. And if this keeps going on, we're going to start testing you. That's an alternative to ordering the immediate MRI. And that comes up a lot, especially in primary care practice. So, the people designing the ACO like that doctor. They like that person who waited and thought the patient would probably be all right. And most of the time, they probably are all right. So why order all these MRIs? So, but how do you pay for the test that didn't get done? How do you even know that the doctor was even thinking about it? Like there's not like a negative fee, like where you know, somehow I was going to order this test that's like $2,400, but I didn't. So I want a portion of the money that I just saved you as an insurance company. You can't tell them that you were confabulating, that you were imagining ordering this test. So how do you do that? Okay, so now I'm going to give you a quiz. One answer A is that it's easy, and answer B is that it's actually not easy and it's kind of complicated to do that. How many people think it's easy and we're just not saying what it is? And how many people think it's complicated? Yeah, it is complicated. It's very complicated. And that's what goes on with these programs. They're all really complicated because essentially you're trying to pay more for the tests that didn't get done. But you don't know what they were because they didn't get done. So what they did, so these programs, and as I said, there's a couple dozen of them, all concocted by CMMI, all of them exclusively for the people who were in Medicare but didn't want the Medicare Advantage plan. That's who this is being inflicted upon, me, in other words. And what they do is they withhold or they force the practice to set aside a portion of the fee that they collect. So if you're in traditional Medicare, Medicare pays 80% of the outpatient bills. So instead of paying you that 80%, they would pay only 60%, hold on to the other 20%. And if you behave badly and you order too many tests through the year, that money would be at risk. You may not get that money because your patients had a lot of testing done. So they withhold the money, but then the other part of what I just said is how do you decide that you were more expensive? So you create other alternative financial flows, and you have to benchmark, meaning you compare how much testing and treatment you ordered and your patients got compared to a national standard or a standard for a rural area. So some kind of standard, a standard for an urban area or a suburb or an area with a lot of minority people. So you could break it down in different ways depending on how much the benchmark average was expected to cost. And then if you do better or worse, you get more, you lose money or you gain money. And then it started to seem unfair. So they tried to, that some people were just sicker. Some people just had sicker practices. So they had to start coding patients for how sick they were, just like in Medicare Advantage. So all that cheating started going on when you're coding how sick someone is. And James Waters talked about all the cheating in Medicare Advantage, which does the same thing. They have to risk adjust. Risk meaning how sick is that person? How likely are their costs to be higher because they got chronic heart failure? So ACO Reach is just one of these 24 programs, and they establish a spending benchmark for a defined population of Medicare beneficiaries that get attributed to the ACO. Now, by the way, that's another issue, is that people in traditional Medicare, I don't even have to have a primary care doctor. I can go to one or not. And they wanted the primary care people to be the ones leading this thing and being penalized or rewarded. but I don't even need a primary care doctor in traditional Medicare, and they haven't changed that yet. So what they did was they said, whoever in the last 2 years, whichever primary care doctor saw you the most times, that's going to be your primary care doctor, even if there were 2 visits and they occurred 23 months ago. And you more recently saw a primary care doctor that you actually like and you want to go to. No, it would be the doctor who saw you twice 23 months ago. So they're assigning who the primary care doctor is, and then you're responsible for all the spending as that primary care doctor. So this is really kind of sketchy, really. Even figuring out who the primary care doctor was turned out to be a perilous step. And then they established a spending benchmark for some comparable population of people in Medicare that are attributed to the ACO, meaning you're the person who's been seen the most by that particular doctor in the last couple of years. And then within ACO Reach, which is just one of 24 programs, there were 2 options. The lower risk one, where the ACOs share 50% of the savings and loss, or the higher risk one, where the ACO actually assumes 100% of the cost. So this wasn't just 20%, this was going to be a higher risk deal. You were really going to lose if your patients were sick, and you were really going to win big if your patients turn out not to be sick. So guess who would tend to do the best? Which demographic in the United States? If they were in traditional, if this were your population and you're a doctor, which demographic do you think would do the best? And your choices are a wealthy suburban population that's well educated, or a minority population that's in a very poor area. And make them a linguistic minority. They don't even speak English very well. And they're poor, and their educational level is low. So they're going to get classified as to whether or not they have heart failure. And which group of people with heart failure do you think do better? Rich people with heart failure or poor people?
Rich people.
Yeah, it's not even close. It's not even close. So the practices in wealthy communities were really able to score in these kinds of programs. And ACO Reach, which actually was rebranded, it had a different name previously, but what ACO Reach did when Biden rebranded it early in his term was they actually gave extra money if you're a minority community. And minorities overall are poorer, though it's not universally true, because Asian Americans are not actually poorer than the general white population. So, but if you were a minority community, you were going to get more money. So, so that was a way to kind of make up for worse outcomes among minorities. Although I would love to see if that one was stratified by poverty, because I think the big driver there is especially poverty. Though, as we learned last week, for maternal mortality, it does seem that race is a big factor, and it's not just, and that may well be the case throughout. There may be many racial disparities, but you always have to, since Black populations in the U.S. are so much poorer than whites, there's always that confounding factor of poverty as being the major attributable factor as opposed to race. But I mean, in general, the ACOs that could attract wealthy white populations were going to do better with the stuff they were scoring on. Go ahead, Zach.
This is just a clarifying question. Is that minority like capitated payment on top of a risk adjusted payment, or did they do the minority like adjusted payment in lieu of already like Or yeah, basically that's it.
Yeah, they were added, it was an add-on. It was novel for that reason, that they were Black people at at a given age, say age 65, a Black population is going to have a higher prevalence of heart failure. They get heart failure earlier because of uncontrolled hypertension, other racism, all the factors that can lead to heart failure. But yeah, they were separating out race and paying extra. And part of this was because all the minority communities and safety net providers looked at this program and they said, no way, we're not doing this. We're going to lose money. So they were trying to buy minority providers and minority communities to get involved in this. And by the way, since the whole point of this is a scheme to provide less care for people, the fact that they even wanted to include minority communities was sort of disgusting, because those minority communities have not been getting enough care. They've been getting too little care. Why do you want to get them into schemes that provide less care? It's out in the suburbs where people often go to a different specialist for each little thing that happens and arguably get too much care. So that was the real irony. Here's the first time they're actually paying separate extra money just based on minority status, and you're doing it to initiate a disincentive program. I mean, to me, it's like, whatever. This is like the United States healthcare system, patch, one patch on another patch on another patch, and here it's truly gone crazy. But anyway, that was what this ACO REACH program did. But I mean, the point in this slide is, like, even within ACO REACH, it's just one of 24 schemes. They're all separate schemes. There's some scheme where money is withheld and then you do or do not get the money based on what happens. They're all complicated. This program even has two separate options, and there's all kinds of rules that govern it. Betty, go ahead. I still haven't finished describing what an ACO could be, but go ahead. You sure
Yeah, we were getting kind of far afield, so I was wanting to kind of pull back and make sure like real basic stuff was understood. And so I'm going to explain something in a really, really basic way, and you tell me if I'm right. And if I'm right, then it may be helpful to the interns that it was broken down to be so very simplistic.
Mhm.
So my understanding from way back in the day when I worked for an HMO briefly, is that HMOs formed because the insurance companies didn't have an incentive to keep you well for a long time. There wasn't an incentive to get preventive care. And the idea was, oh, let's keep people healthy, health maintenance organizations. And my understanding was that they were typically nonprofits. Then my impression was that accountable care organizations were introduced with the notion of, well, there'll be more motivation to control costs more if we, the whole thing that Marvin's been talking about, and having doctors make less money if they order more stuff. And so the primary difference, my understanding between an HMO and an ACO was that an HMO was typically nonprofit, and an ACO was typically for profit. And the
No.
ACO, no?
Oh, no, not at all.
Okay.
No.
So are HMOs also for profit?
Yeah, most of them now are. Okay. You're using the term HMO. And I
Does
guess
anybody even talk about HMOs anymore? Or is it all just talking about ACOs?
HMOs is a type of insurance company that suggests that they're going to not discourage primary care and not discourage preventive care, but encourage those two things.
Yeah.
But it's all mushy now. Everything fades into everything else, because most of the HMOs in this country are for-profit insurers like United Healthcare. Like if you
They're an
look at the
HMO?
Medicare exchange,
Oh.
it'll say United Healthcare PPO option, United Healthcare HMO option, United Healthcare, the different options. But it's basically become an intrusive insurance company. whereas Kaiser in the original thing Mackenzie was asking about, that was called a staff model HMO, where where they were providing the care and serving as the insurance company. But with what United Healthcare, this conception of HMO, it's now you can just have a for-profit. It's basically an insurance company, a for-profit.
I didn't
insurance
realize that
company.
they called those HMOs. I thought those were ACOs. And there's a more of a range. Instead of only being the staff model, there could be a little bit more of a range of how they did things. But I didn't realize that those were called, that the for-profit ones were called HMOs. My error.
Right. So what an ACO is, it's the only difference, it could be for-profit or not-for-profit. So we had one that was not-for-profit in Vermont for a while, then they changed to for-profit status. It didn't matter. They were doing the same thing. Anyway, the difference is that in a regular insurance company or an HMO, so now they're sort of the same, an intrusive insurance company that should be covering preventive care. Well, I mean, that's sort of what insurance companies are these days, or HMOs. So they're an intrusive insurance company. They're going to pick at you and not, make you do prior authorization or deny payment. So that's the insurance companies that we're used to these days that we hate. So what this is, it's a scheme where you have a non-intrusive insurance company that's still there, paying for all this stuff, like traditional Medicare does. It pays for everything. And I have to tell you, my supplemental insurance plan that I buy to cover the 20% that Medicare doesn't cover, they are legally not allowed to deny care for anything, ever. There is no prior authorization. It's Medicare itself that can sometimes deny payment. And they do that 20 times less often than United Healthcare does in their Medicare Advantage plans. So they do it whole lot less. And that wasn't good enough. They wanted more disincentive schemes, the people who are buying into this whole ideology. And so they left all that payment alone so that I still pay for my supplemental plan. I still pay Medicare Part B premiums, and Medicare still pays for everything. But even though I'm paying the same way and I feel like I'm getting all the same care, there's this ACO lurking in the distance. And it's not denying payment for any specific procedure or requiring any prior authorization. It's just giving my doctor a disincentive scheme. So if the doctor lets me get a lot of care, he or she will lose money. It's pure capitation, no intrusion, no picking at any individual procedure. It's just a financial construct added on to all the complexity we already had to take some of the money so that the doctors wouldn't get it until the recalculation at the end of the year as to how expensive a doctor I turned out to be. So it's grafting onto an existing insurance scheme, a financial disincentive scheme without intrusion. This is complicated. The system was.
So, and Marvin, you've been using the word "this" a lot. And so if we could just kind of clarify which "thises" were this.
Okay.
So we were talking first about HMOs, and then we're talking about some of the things that I thought were ACOs are actually still HMOs, even if they're for profit, and even if they're not capitated. I thought that HMOs were like a capitated system. So what we call, like today, there's not that many not that many capitated systems, but it's more these other systems of how do we figure out how to make doctors order fewer things and patients not be able to get access to the things that they need. Is that both ACO? Like, what's the difference between HMO and ACO?
Right. That's the question you already asked, and I'll try to answer it again. An HMO is an insurance company.
Okay.
That's supposed to provide good coverage for preventive care and primary care. They pick at you, they require prior authorization, you know, they can deny care. They're regular old insurance companies. An ACO is specifically grafted onto the scheme where you have a non-intrusive insurance company.
So in an ACO, are
It's a
all the
graft, it's an
doctors
extra graft of a financial scheme.
in an ACO, are all the doctors like either are all the doctors employed by the insurance company still, or are they in private practice or hired, you know, or salaried by the, you know, clinic or hospital or whatever, but their salary is separate from the insurance company?
Okay, so in 1973, HMO meant a staff model HMO, where like Kaiser, where all the doctors are employed. They're rare. So the term HMO now is generally used to mean an intrusive insurance company that's providing preventive and primary care well. Ideally without all the copays and deductible stuff, especially deductibles. And it's comprehensive care. It's a little iffy here, but usually a super high deductible plan would not call itself an HMO. They're still an insurance company, but HMO really meant you were going to be encouraged to get preventive and primary care. That's left over from 1973 when they first started. An ACO is only grafted onto a situation, either like in Vermont's case where the system as a whole cost too much, so they were going to try to create yet another disincentive scheme onto whatever there was, and to every insurance plan in the state was supposed to get involved in this. But what you're seeing in reality more often now is just Medicare HMOs. I'm sorry, Medicare ACOs, sorry. So a Medicare, and it did not apply to people who signed on to Medicare Advantage. So in other words, when you enter Medicare, you choose between a Medicare Advantage plan and staying on traditional Medicare. If you stay in traditional Medicare, you pay a lot more upfront. Because if you take Medicare Advantage, your entry costs your premiums for the year might only be $500, $400. Whereas if you get into traditional Medicare, you're paying for all the Medicare B and as well as a $2,000 or $2,400 a year supplemental plan. So your entry costs in traditional Medicare are high, but there was no insurance company screwing around with your care. So that was the motive. So it's now become a wealthy person program. And the people left in traditional Medicare were the target of the ACO scheme. And most of the ACOs in the country are involved with Medicare, and usually Medicare only. It's only in places like Vermont where they were interested in experimenting that it got to be something more than that. So across the country, it's mostly grafted onto traditional Medicare.
So I can
a disincentive scheme onto traditional Medicare.
So I can try to restate what I think there's a difference between an HMO and an ACO now, but does one of the interns want to try to take a stab at it?
I nominate Trinity. I think she did a really good job at the beginning.
So we're talking about ACOs versus HMOs. So my understanding from this conversation was that HMOs are just like regular insurance companies, but they have their like network and all of that is more limited. And they're just regular insurance companies, but then ACOs were just the group of doctors where the goal is to cut costs and be more cost effective. But
under
then
the pressure of a financial disincentive.
yes, right. And then with the HMOs, if it is like a Kaiser, like a staff model HMO, which I think is only really Kaiser that does it now, then they provide the care while serving also as the insurance company. But these days, pretty much all the HMOs are like a regular insurance company that just limits who patients can see.
They don't want you to say it that way, Srini. They want you to say they provide generous preventive care and primary care and coordination of care. That's always the term, coordination of care. But
And
you're right. They're also going to look at expensive care and go after it. Yeah.
so the health maintenance organizations have an emphasis on having a primary care provider. And then they have networks to try to control the costs of who they'll refer to. And they've negotiated contracts to try to keep those prices down. And the ACOs,
Wait, an ACO is not an
May not.
insurance company.
an ACO is not an insurance company.
That's right. I told you I already paid for my Medicare and my supplemental insurance plan. They're paying. And the money they're paying is being diverted into this ACO financial scheme.
So that was true in Vermont with OneCare, but is that how it works in other places? Is that like the
Yeah,
normal way
OneCare
the
never
ACOs
paid
work?
for anything. OneCare never paid for anything. It's an ACO. It never paid for anything. It just took the money and mished up with it and did this big financial recalculation at the end of the year to figure out who got extra and who got less.
And then the difference between an ACO and the MSO is that the ACO isn't necessarily doing anything with the individual doctor's practices, billing, or any of that other stuff. They're just focused on the reimbursement issues and whether they can, get more money from the payer or not.
An MSO is just a private sector subcontractor where a practice wants to not do billing. So they
Okay.
subcontract it to a management service organization. And as I said, some of the management service organizations do every single thing that managers do. So they could literally take over. And if they're well financed, they could buy the whole damn practice and make the whole practice corporate. So that's just a term for subcontracting, management services organization. An ACO is a scheme, a financial scheme superimposed on an insured patient population. It's all Medicare. It's pretty much only Medicare in red states and in most states in the country. It's grafted onto Medicare because of this scheme that we have to control costs, and this will somehow do it. And it's
So
moving money around, creating fund pools of money that are then reevaluated at the end of the year. And it always involves these benchmarking schemes to see how you rate as an economical provider of care.
So when you talk about it's grafted onto Medicare, you're talking about it's grafted onto traditional Medicare.
Yes, traditional Medicare.
It's unrelated to Medicare Advantage.
Right.
The Medicare Advantage is more the HMO type model where you have your primary care provider that you're supposed to see in the neural networks in that way.
Yeah, exactly. Medicare Advantage is just another intrusive HMO insurance company.
Okay, thank you.
I think it's pretty safe to use the terms HMO and insurance company pretty synonymously. In fact, the only situation I know where there is literally no intrusion by an insurance company is the supplemental plans in Medicare because they're legally not allowed to. I don't know of any others in the United States.
So it's actually 204.
Oh, okay. Well, let me finish then. So if the ACO's actual spending for its beneficiary comes in below the benchmark, the ACO shares in the generated savings with CMS. If their actual spending exceeds the benchmark, ACO shares in the losses with Medicare. Depending on which of these schemes they chose, how much they lose, how much they don't lose. ACO REACH moves away from traditional fee-for-service, blah, blah, blah. They receive prospective risk adjustment payments based on which of these schemes they choose. They can have primary care capitation where they're getting a fixed amount of money each month out of this fund that was diverted. And then preferred providers are the specialists who agree to get paid less through fee for service. So there's all these terms within each plan. They're all very complicated. And so I wanted to summarize it for you guys. So we could, and this is the rhetoric, they give primary care people more predictable revenue schemes, allowing for, quote, investments in care coordination. Those never happen. They don't exist, or they exist so rarely that they're minimal, that nobody's doing anything different at all. Other initiatives to improve patient care and manage costs effectively, as if other doctors are trying to spend more. I mean, it's just all crazy. Anyway, ACOs can also utilize a portion of their funds to provide incentives for beneficiary engagement, such as a gym membership. You can pay them to go to a fitness center. So that could be done. I don't think many are doing that. Important part of this are quality bonuses. They're getting paid more for taking on or for providing, quote, higher quality care. And y'all know that means they're going to be focused on those things they know are being measured. And they're going to nag their providers to get those things done. So if it's influenza vaccine or COVID vaccine, you can bet your provider is going to nag you on that and not bother you with things that aren't being, not a high stakes measurement. But the rhetoric is that incentivizes providers to provide high quality care, which they didn't want to do on their own, and patient-centered and preventive services, because the preventive stuff is easy to measure. And then health equity, the ACO REACH model paid extra for care in minority communities. Now note that there's also a financial negotiation between the entity and primary care providers it's trying to recruit. So I want to focus on the word entity. How are you guys thinking that word, that I'm using that word? Like, why is there an entity? Who is it and what is it doing that the providers can't do on their own?
All the administrative work and like even collecting the data to be able to report to the ACO.
Okay, number one, administrative work. Number two, data collection. What else is it doing? It's usually a corporation, but we'll just assume it's a corporation. It's collecting data. And what was the other thing you said, Zach?
Just like the administrative work of like filing the
Administrative.
paperwork, making sure it gets to the ACO.
Exactly. There's one other key thing that the entity can provide, and that's money. They have enough money to handle the risk. Because what if it's an expensive year? What if there's a pandemic and everybody's getting sick and they're all in the hospital? I guess they weren't during COVID, but anyway, let's say it's an expensive year for whatever reason, and they got to be able to absorb the risk because a little primary care doctor can't possibly absorb risk in case his or her patient's population turns out to be sicker. Doesn't have enough statistical significance. You got to have a much larger denominator, a larger population. So there's an entity. Now the entity could be something like Kaiser, something that's large. Or some entity that's very large that has, 100,000 patients in it or 500,000 patients. Because the risks are going to average out year to year for the most part. So, but most of the entities are corporate and the ones that are heavily involved, and many of them are even private equity financed. So they're taking on this risk, and private equity capital takes on a risk under one circumstance. And what do you think that is?
They're able to make money.
Yes, they think they're going to make money. Exactly. So the entity is getting into this because they don't think the odds of the primary care doctors doing well at controlling costs. They think that the odds are stacked in favor of this deal working out for them. And so the bottom line, this is sort of a summary. ACOs are administratively complex. They're too complex for the average busy practitioner to even want to understand. And it would be too financially risky for an individual doctor or even a practice with 20 doctors to take on. You need a much larger denominator. So an entity with a lot of money is needed. And for both of those reasons, that it's complicated and you need a lot of money to start with, well-financed management services organizations who already are good at manipulating data and metrics and all that stuff and moving money around, they have been putting out their shingle that we can be the entity if you, primary care doctor, choose us. Or they could start out applying to Medicare and then try to recruit primary care doctors. So it could go either way. The primary doctor could try to find an entity, or the entity could try to find primary care doctors, and so they can get involved. And here's why. This is the key thing to understand, is that they're all getting overpaid. And that's why the private equity companies think they're going to make a profit, not because they think these primary care doctors are efficient, but because they know that Uncle Sam is overpaying. And so the motivation of both the entity and the primary care doctor is because they know they're going to get more money out of the deal. This is also the reason why the AMA supports value-based care, because all this value-based care, all these schemes have led to overpayment. And primary care doctors are not losing money. It's only with Trump talking about that they're even going to force them to be in a negative risk, in a lose out, in a scheme where they might lose money. So that's the genesis of the physician support for the program. It was a way to make a marriage of convenience with some entity so that you can profiteer off Medicare's overpayment. And so that's sort of fundamental to understanding it. And so obviously the CMI models have failed at controlling costs, but for political reasons, they're being continued. You can speculate on the reasons why nobody does anything about it. There was the Congressional Budget Office, as I mentioned, did a big study September 2023 showing that all this value-based care stuff has been at best neutral financially, but nobody batted an eyelash. It never sort of stopped the program. Biden didn't stop it, and Trump seems to be making them forcing them into negative risk, into potential money losing schemes. But I don't know how that would go if you force providers. I don't know what would happen if you force providers into this stuff. So anyway, are we now clear at least that an ACO is completely different ballpark than what an MSO is, which is just subcontracting out services? Okay, then you've shut me up, thank God. And that's my last talk in the internship, so I'm like thrilled. I'm sorry, it's such a difficult topic. Anyway, we're breaking, and then